And in the first section this morning is going to be all about atrial fibrillation. And so our first speaker is going to be Dr. Malini Madhavan. She is a clinical electrophysiologist who has special interest in atrial fibrillation and outcomes of ablation procedures. And she's going to talk to us about the diagnosis and stroke issues having to do with atrial fibrillation. So we'll get started with her questions. The first one is a 67-year-old woman with a history of symptomatic paroxysmal atrial fibrillation undergoing pulmonary vein isolation. Her past history is significant for hypertension. 6 months following the ablation procedure, she has complete freedom of symptoms of AF. She's on metoprolol and apixaban. She wonders if she can stop the apixaban. So 6 months following a pulmonary vein isolation. What's the next best step? Stop the apixaban and start aspirin. Perform a 48-hour ambulatory ECG and stop if there's no AF recorded. Just continue the apixaban, or stop the apixaban and refer for left atrial appendage closure. Okay? I think you can improve on that. A 77-year-old woman with a history of atrial fibrillation, hypertension, and mechanical mitral valve replacement is referred for management of her AF. She's treated with amio, metoprolol, and warfarin. She has a normal CBC. Her INR is 3.1, a creatinine clearance of 45. Her EF is normal. She has trivial MR with severe left atrial enlargement. She's heard about dabigatran and is interested in switching. Which of the following is true regarding dabigatran in this patient? It can be safely started at a reduced dose of 75 BID. B, concomitant use with amiodarone will reduce the plasma concentration of dabigatran. C, dabigatran is contraindicated in this patient. Or D, the risk of intracranial hemorrhage is similar between dabigatran and warfarin. Which of those statements is true? Okay. And question number 3 is an 82-year-old woman presenting with new onset palpitations and fatigues. She has coronary disease and hypertension. Her weight is 58. Her pulse is 142 and irregular. Her blood pressure is 128/76. She has a fib. CBC and TSH are normal. Her creatinine is 1.6, which gives her a low GFR at 33. Her echo shows a normal EF with severe left atrial enlargement. She's on metoprolol. She has complete resolution of her symptoms, and her heart rate is 92. While discussing strategies to prevent stroke, she states that she is not interested in warfarin therapy. Which of the following is the best step in the management of this patient? Give her aspirin plus clopidogrel. Start her on apixaban. Start her on rivaroxaban. Start her on a lower dose of apixaban, or aspirin once a day. All right, I think you have some opportunities to teach. Thanks for being here, Malini.
Thanks, Dr. Hammond. So atrial fibrillation, as we all know, is the most common sustained arrhythmia in adults. And it's projected that by the year 2050, about 5.5 million Americans will be affected by atrial fibrillation, and about 50% of those affected by the year 2050 are going to be over the age of 80. So by far, of all the arrhythmias that you're going to hear about today, atrial fibrillation is going to be the most common one, and you can definitely expect a number of questions on this on the board exams, and also this is going to come up a lot in practice. So my job today is to talk about a little bit about the diagnosis and the mechanisms of atrial fibrillation, and then we will focus on strategies to prevent strokes in atrial fibrillation. Dr. Friedman, who's going to follow me, is going to talk about more about the actual treatment of atrial fibrillation. So the diagnosis of AF is mainly an electrocardiographic one, and we'll talk about that and some of the related atrial arrhythmias. So let's take a look at this ECG. We see that there is irregular atrial activity here and no repetitive P-wave morphology that keeps repeating itself, an irregular RR interval. So this is the EKG marker for atrial fibrillation that everyone in this audience is going to be able to recognize. Now, why is this not atrial flutter? This is not atrial flutter despite the look of some organization in V1, because there are certain parts of the ECG that clearly look disorganized, irregular, and if you see atrial fibrillation in some part of the ECG, it is atrial fibrillation, not flutter. And of course, fib flutter is really not an entity, and the differentiation between fibrillation and flutter is an important one to make because it's going to guide how we are going to treat this. Let's contrast that to atrial flutter here, which has a fixed flutter morphology with electrical activation throughout the cycle length of the arrhythmia, and the flutter morphology keeps repeating itself. There is a fixed morphology. Moving on to the atrial tachycardia. So when someone talks about atrial tachycardia, what they typically mean is a focal source in the atrium that is firing automatically, causing centrifugal spread of atrial activation from that focus. Most common cause is, of course, automaticity, so it's going to behave similarly to another automatic focus that we are familiar with, the sinus node. So that it's going to be very sensitive to autonomic tone. If a patient is active, it speeds up. If they are inactive, it slows down. And the EKG diagnosis and the hallmark is really a fixed P-wave morphology that's going to look different from the sinus P-wave. And there is going to be regular tachycardia and an isoelectric line between the consecutive P waves. So that's the hallmark on the ECG for focal atrial tachycardia. Now, atrial tachycardia can also be because of macro re-entry in the atrium with a large circuit, a large electrical circuit in the atrium. And in this situation, it is macro re-entrant atrial tachycardia is basically synonymous with what we call atrial flutter. And the ECG hallmark is really continuous atrial activation throughout the cycle. So there is really no part of the atrial cycle length where there isn't electrical activation in the atrium. And in the majority of situations on the ECG, it's going to be recognized as continuous flutter waves. So when you see a ECG of an atrial flutter, the first distinction to make is going to be one between typical atrial flutter and atypical atrial flutter. And this is predominantly an ECG diagnosis to make. So what does typical atrial flutter look like? You're going to see negative flutter waves in the inferior leads. So 2, 3 AVF will have negative flutter waves. And when you look at V1, the terminal portion of the flutter wave should be positive. In other words, it's called terminal positive in lead V1. So if you see this pattern, it's called typical atrial flutter. Important to recognize because in most situations, this essentially means that there is a circuit in the right atrium that's traveling in a counterclockwise fashion around the tricuspid annulus. You will also hear the term cavo-tricuspid isthmus-dependent flutter for this typical atrial flutter. What that really means is that there is an isthmus of critical tissue between the tricuspid valve and the IVC that's important to keep this flutter circuit going. So as a corollary, if we ablate or burn in this cavo-tricuspid isthmus, we can reliably get rid of this typical atrial flutter. Hence the importance of being able to recognize this entity on the ECG. Any other flutter morphology that doesn't look like what we talked about, so anything that doesn't look like negative in the inferior leads and terminal positive in lead V1 would be considered atypical atrial flutter. This can come from several different portions of the right or the left atrium. And where it comes from is really a concern for electrophysiologists and not within the scope of our talk today. So let's do a question. Take a look at this ECG, and the question is, what is the rhythm? Is it sinus with PACs? Number 2, atrial fibrillation. Number 3, multifocal atrial tachycardia. Excellent. So most people recognized that this is multifocal atrial tachycardia. The ECG hallmark is the presence of multiple different P wave morphologies. So at least 3 or more P wave morphologies, irregular RR interval with rates over 100 beats per minute, and an irregular PR interval. Important to recognize because this is most commonly seen in patients who have pulmonary disease, theophylline tach toxicity and such. And the management is going to be focused on rate control and management of the underlying issues, typically the pulmonary issues, and so very important to recognize. So to summarize how to recognize the irregular RR interval tachycardias, we first have atrial fibrillation here. We can see irregular atrial activity, no fixed P wave morphology with the irregular RR interval. And then we have atrial flutter, which has a fixed flutter morphology with continuous activation throughout the cycle length of the tachycardia. And then we have multifocal atrial tachycardia, which also has an irregular RR interval, but we can see distinct P waves with at least 3 or more P wave morphologies. We'll discuss briefly about the mechanisms involved in atrial fibrillation. Arguably, it's very complex and only incompletely understood. But what we do understand is that for atrial fibrillation, there is typically an initiating factor, also called a trigger. So when we look at this ECG, we see that it starts out with sinus rhythm, and then there is transition of sinus rhythm to atrial fibrillation. And it seems to start with a bunch of PACs from the atrium. So there is often a trigger or an initiating factor for atrial fibrillation. And the second piece of the mechanism is that once it is started, there is a mechanism or a substrate in the atrium that keeps it going. So two broad clinical patterns of atrial fibrillation to recognize would be paroxysmal atrial fibrillation and persistent atrial fibrillation. Now, when we think about paroxysmal atrial fibrillation, it is all about the trigger. So there is a trigger in the heart that starts the fibrillation time and time again. When we think about persistent atrial fibrillation, the trigger is important, but what is more important is what keeps it going in the atrium or the substrate. Typically, over time, there is overlap in the same patient with paroxysmal and persistent. They are not distinct entities. And it's not uncommon to see that paroxysmal would transition slowly to persistent in the same patient over time, which essentially signals the increasing importance of substrate in the atrium for maintenance of atrial fibrillation. Important to recognize these two entities, not only to think about mechanisms, but also to think about what type of treatment strategies is going to work out in the two different forms. When we think about triggers, by far the most common trigger for atrial fibrillation arises in muscle sleeves that seem to extend into the pulmonary veins. This is the target for ablation strategy that we will be talking about later. Triggers can also come from the other veins in the heart, such as the SVC and the coronary sinus, and also from the general atrial myocardium at particular locations. Now, once atrial fibrillation is started in the atrium, there are going to be changes that are the result of atrial fibrillation in the atrium that causes a tachycardia-induced atrial cardiomyopathy. And this essentially makes sure that there is a higher likelihood of sustaining atrial fibrillation in the atrium. So in other words, this is also called atrial fibrillation begets atrial fibrillation. So the changes can be electrophysiologic remodeling. With atrial fibrillation, there is calcium overload in the atrium, and consequently a down-regulation of the L-type calcium channels, a down-regulation of the ITO channels, and eventually a shortening of the action potential duration and shortening of the atrial ERP in the atrium. Some of this remodeling is also anatomic or structural. There is increase in atrial size over time. There is loss of atrial myocytes and fibrosis. And the end result of this electrophysiologic and anatomical remodeling is that multiple wavelets and rotors are more likely to sustain in the atrium and lead to more persistent forms of atrial fibrillation over time. So to summarize the mechanisms, we have triggers that come from the pulmonary veins and other sources in the heart and the veins associated with the heart, which start the atrial fibrillation. The autonomic innervation to the heart plays a huge role in both the initiation and the maintenance of atrial fibrillation. The autonomic innervation goes mostly through the ganglionated plexi that are located in the heart, typically around some of the veins that we talked about that can act as triggers. And again, this is not only important for the trigger, but also the substrate. And once we have atrial fibrillation initiated, the electrophysiologic mechanism by which it's maintained involves multiple wavelet reentry and rotors, which are essentially large three-dimensional reentrant areas. And once we have atrial fibrillation going, we talked about all the changes that can happen in the atrium, electrophysiologic remodeling that leads to the more persistent forms of atrial fibrillation and higher likelihood that it's going to persist in the future. So we'll switch to the second objective of the day, which is really to talk about stroke and atrial fibrillation. There is no doubt that atrial fibrillation increases the risk for stroke. When we take all comers with AF, there is about a 5-time increased risk for stroke compared to someone who doesn't have atrial fibrillation. Now, the important thing to recognize about stroke risk and atrial fibrillation is that two different patients with exactly the same phenotype on the ECG, that is atrial fibrillation, may not have the same risk for stroke in the future. There are a number of clinical factors within the heart and outside which seem to modulate what the risk for stroke is in a patient with atrial fibrillation. By far, the most important factor is advancing age, followed by a history of stroke or TIA. Some of the other risk factors are female gender, hypertension, a history of diabetes, and then there are a number of cardiac conditions themselves that increase the risk for stroke and AF. So things like systolic heart failure, coronary artery disease, rheumatic mitral valve disease, presence of a prosthetic valve in the heart, and hypertrophic cardiomyopathy are all associated with an increased risk for stroke in a patient with AF. So let's think about just one of these mechanisms to illustrate the point. So when you think about atrial fibrillation and why there should be an increased risk for stroke, there is a simplistic way of thinking about which is atrial fibrillation leads to poorly organized contraction or loss of atrial contraction. There is going to be stasis of blood in the atrium. There is going to be formation of thrombus and potentially embolism of this thrombus causing stroke. But the thing is, it's only part of the story. There is a lot more in a patient with atrial fibrillation that contributes to that risk. So when you think about hypertension, yes, hypertension is one of the factors that makes it more likely that a patient would develop atrial fibrillation, and consequently, as a result of this formation of clot, increase the risk for stroke. But it's important to remember that hypertension by itself can also increase the risk for stroke by independent mechanisms. So it has effects on the vascular endothelium, it has pro-inflammatory effects and pro-thrombotic effects that by itself, independent of the atrial fibrillation, also increase the risk for stroke. this is, I think, an extremely important concept to keep in mind as we look at who to anticoagulate in the future. Even if we think that we got rid of atrial fibrillation in a patient, say by giving an antiarrhythmic or doing an ablation procedure, it does not seem to get rid of the risk for stroke sufficiently to say that the patient does not require anticoagulation. So these patients should still be risk stratified according to some of the schemes that we are going to be talking about. So we'll do a question at this point. So we have a 68-year-old woman, presents with AF, and it is very well controlled, rhythm controlled on flecainide. She has no significant past medical history, and the question is, which of the following is indicated to prevent a stroke in this situation? A, aspirin, B, warfarin, and C, no therapy. All right, excellent. So 72% thought it's going to be warfarin. And we are going to come back to this question and address why the other options are not a good one. So everyone in this room is familiar with the CHADS-2 risk stratification scheme. And I have this in your syllabus for review later. Now, what the CHADS-2 score does very well is to identify patients who are at high risk for atrial fibrillation. So no doubt, as the risk number increases, as the score increases, there is a progressive increase in the annual risk for stroke in these patients. But one of the limitations of the CHADS-2 score is that it doesn't do very well in identifying who's at low risk and doesn't need anticoagulation. So if you look at patients who had a score of 0 or 1 on the CHADS-2 score, they still have a 2 to 3% annual risk for stroke, which is pretty significant, I think. So to improve the discriminatory value of these scoring systems for patients who are at lower risk, the CHADS-2 VASC score was developed. Now, the current 2014 AHA guidelines and the ESC guidelines all recommend that we use the CHADS VASC score for risk stratification in atrial fibrillation. And by the end of the day today, I want everyone to be extremely comfortable with this, apply it on your exam, and also apply it in your offices. So how does this differ from the CHADS score? There is a double hit for age. So if a person has age between 65 and 74, they get one point. People over the age of 75 get 2 points. There is one point for female gender and 1 point for the presence of vascular disease. So vascular disease would include prior myocardial infarction, peripheral arterial disease, and the presence of aortic plaque. And how does the CHADS-2 VASC score perform? It seems to do extremely well in identifying patients who are at the lower end of the spectrum and the low-risk patients. So if a patient truly has a CHADS VASC score of 0 or 1, we can feel comfortable telling them that they truly are low risk for a stroke and perhaps won't benefit from anticoagulation. So I think this is the main advantage of the CHADS VASC score, where it helps you identify who does not require anticoagulation. The flip side of anticoagulation is, of course, bleeding risk, and the average annual risk for bleeding from the several trials that have looked at warfarin is about 1% per year, and this is for major bleeding. And there are several scoring systems that have been developed to look at the risk for bleeding. The HAS-BLED score is probably one of the best ones. And if a person has a score greater than or equal to 3 on the scoring system, they are at increased risk for bleeding. The problem with the score is the predictive accuracy is modest at best. So the current guidelines, while they recommend that we calculate the score and include this in the discussion with patients, it doesn't, high score really doesn't preclude using anticoagulation. So if a patient still opts to be on anticoagulation, it's important that we have this discussion and also closely monitor the anticoagulation in these situations. I really don't think this is going to show up on the boards as such, so you don't have to remember it by heart, but the CHADS VAS score is something that you do need to be able to calculate quickly. So this is probably the most important slide of this talk. Who to anticoagulate? Who should receive an anticoagulation? So the first question you want to ask is there valvular atrial fibrillation? So that would be defined as rheumatic mitral stenosis, a history of mitral valve repair, and the presence of mechanical or bioprosthetic heart valve. So if the answer to this question is yes, you want to give the patient warfarin. This is not a situation where a NOAC or a novel anticoagulant should be used. The second question you want to ask is there a history of hypertrophic cardiomyopathy? Now, this condition by itself is associated with a high enough risk for stroke with AF that the guidelines recommend that we anticoagulate these patients regardless of what the CHADS VAS score is. And for them, it can either be a warfarin or a novel anticoagulant. If the answer to these questions is no, then we calculate the CHADS VAS score. If the score is greater than or equal to 2, so a score of more than 2 or 2 would indicate that the patient should be considered for warfarin or novel anticoagulation. If the score is 0, no antithrombotic therapy is indicated, so this would include not only an anticoagulant, but also aspirin. So if the score is 0, you don't give them anything. If the score is 1, the guidelines kind of waffle a little bit here and say that there's a class 2B indication to doing either no therapy or aspirin or an anticoagulant, but I think most people in practice, including myself, would probably recommend aspirin in this situation. That brings us to another important question that comes up. What do you do if a patient is well rhythm controlled, and meaning they don't have atrial fibrillation, at least that's clinically recognizable, at least there is no symptoms of it, based on the fact that they've either had an antiarrhythmic or a successful ablation procedure? Important to remember that, again, the CHADS-2 VAS score should be used to guide stroke prophylaxis in these patients. And just the fact that we have rhythm controlled them does not mean that they should not be on an anticoagulant. So coming back to the question that we looked at, we have a 68-year-old woman who is well controlled on flecainide. If we had looked at the old scoring system, the CHADS-2 score would have been 0, but the CHADS VAS score is 2. And in this situation, warfarin should be considered, and I think the majority of the audience recognize this, and that's excellent. So the next question is which anticoagulant to use? Now we have the vitamin K antagonist, warfarin, but we also have all the novel anticoagulants that have been approved recently. Now we have 4 of these approved. And the development of these novel anticoagulants really came out of the fact that there are several limitations to warfarin. Warfarin is an excellent and very effective drug in being able to prevent strokes, but it has a number of things that are serious limitations. So there is a very narrow therapeutic range as far as the INR is concerned. There is need for monitoring of the anticoagulant effect, and also a quite variable and unpredictable type of anticoagulant effect depending on genetic polymorphisms, food and drug interactions, and overall a slow onset and offset of action with warfarin. So that brings us to the novel anticoagulants. So I'm going to call them NOACs for short through the rest of this talk. The first one to be approved was dabigatran. Dabigatran is a direct thrombin inhibitor. So the mechanism of action is fair game for your board exams. Dabigatran is a direct thrombin inhibitor that can be given orally. The other 3, rivaroxaban, apixaban, edoxaban, are all inhibitors of activated factor 10. I'm going to briefly go over some of the trials that looked at novel anticoagulants and compared it to warfarin. But we'll highlight some of the common threads through these trials. All these trials have been large trials, several thousand patients, 14 to 18,000 patients, and they have all compared one or the other novel anticoagulants with warfarin. They all enrolled patients who did not have valvular atrial fibrillation. So again, going back to valvular atrial fibrillation, there is no, I won't say no, but either no or no data or very limited data that indicates that they should not be used in patients with valvular atrial fibrillation. The other common thread through these trials is that they are all non-inferiority trials. That is really a testament to how well warfarin works. So the main aim of the trials was to prove that the NOACs are as good as warfarin. And the first trial that was published was the RELY trial, which looked at dabigatran versus warfarin. Here, dabigatran was given in two different doses, 150 milligrams twice a day and 110 milligrams twice a day. And when looking at the primary endpoint of stroke, the 150 milligram twice a day was superior to warfarin in preventing strokes, and the lower dose, 110 milligram, did just as good as warfarin. Currently, what is available in the US for use is only the 150 milligram dose. When looking at the safety endpoint, major bleeding, dabigatran at 110 milligrams had a lower risk for major bleeding compared to warfarin, and the higher dose had a similar risk to warfarin. But what is important in this trial is that there was a significant reduction in intracranial hemorrhage with both doses of dabigatran compared to warfarin. The second one to come out was ROCKET AF, and comparing rivaroxaban at 20 milligrams once a day to warfarin. Again, rivaroxaban was non-inferior to warfarin in reducing strokes and had a similar amount of major bleeding episodes with rivaroxaban compared to warfarin. But what is important to recognize is that, again, with rivaroxaban, similar to dabigatran, there was a reduction in intracranial hemorrhage and a reduction in the number of fatal bleeding compared to warfarin. Apixaban was studied in the Aristotle trial and compared to warfarin. It showed that apixaban was indeed superior to warfarin in being able to prevent a stroke and had a much better track record in preventing major bleeding, so lower risk for major bleeding and lower risk for intracranial hemorrhage with apixaban compared to warfarin. The latest kid in the block is edoxaban. It was studied in the ENGAGE AF TIMI 48 trial. Edoxaban at 60 milligrams given once a day is non-inferior to warfarin, and edoxaban was also associated with a slight reduction in major bleeding compared to warfarin. So I have basically summarized all these trials for you in one slide for you to go home and review. I'm just going to highlight a couple of things here. All these drugs were noted to be non-inferior to warfarin, with the exception of dabigatran at 150 milligrams, which was superior, and apixaban, which was also superior. And important to remember that intracranial hemorrhage, a dreaded complication, was lower with the NOACs compared to warfarin. So there are several advantages to the NOACs, including the predictable pharmacological profile, no need for monitoring, fewer food and drug interactions, and of course the reduction in intracranial hemorrhage. Cost seems to be a major disadvantage right now, but other things to keep in mind is dose adjustment is needed for renal dysfunction. There are no reversible agents, at least currently available. There are some in development, but nothing that's been approved for use. And strict compliance is needed. So non-compliance is not an indication to start a NOAC. If a patient misses 1 or 2 doses, they are left unprotected for that period of time. And this is quite different from what warfarin will do. Again, I have summarized the main features of these NOACs for your review later in your syllabus. Couple of things that I want to highlight on this slide. One is elimination or excretion of these drugs. For most of them, there is a substantial elimination through the kidneys. except for apixaban, which has a 25% renal clearance and a predominant fecal clearance. The other thing that I would like everyone to kind of imprint in their minds is dose adjustment for apixaban. Typical dose that is used is 5 milligrams BID, but if 2 of 3 risk factors are present, then the recommendation is to reduce the dose in half to 2.5 milligrams BID. So what are the 3 risk factors? One is age over 80, weight less than 60 kilograms, and creatinine that's greater than 1.5. So if 2 out of these 3 are present, there should be dose reduction for apixaban. It's important to assess renal function before starting NOVAX. If a patient has reduced renal clearance, there is dose adjustment that is needed for all these drugs. And one of the things I would really like to highlight is if the creatinine clearance is less than 15, so severe renal disease, or if a patient is on dialysis, we should not be using NOVAX in those patients. Warfarin would be the drug of choice for those patients. And finally, there is a lot of potential for drug-drug interactions with these medications, and this can also be a fair question for your boards. I have made a summary of some of the common medications and interactions in your slides, and I would really like everyone who's going to sit on the exam to review this a few days before your exam. But briefly, all the 4 drugs have elimination through the P-glycoprotein system. So anything that's going to inhibit the P-glycoprotein system, including amiodarone, dronedrone, verapamil, and quinidine, will all increase the levels of NOVAX and make it more likely for bleeding to happen. Rivaroxaban, apixaban, and edoxaban are all substrates for the CYP3A4 system. So all CYP3A4 inhibitors are important to watch out for. And this is just a short list that can be easily kept in mind and might show up on your board. So diltiazem, some of the antifungals, the macrolide antibiotics. So who is a good candidate for a NOVAC? I think the dominant factor is often patient preference. So we have to have a thorough discussion about all the advantages, disadvantages that we talked about. But there are a few patients who probably are very good candidates. So those include patients who've never been on warfarin, who are naive to warfarin, patients who are having trouble controlling their INR on a stable dose of warfarin, patients with preserved renal function and no potential for drug-drug interactions. And in this regard, watch out for drugs like dronedrone, amiodarone, verapamil, and quinidine. And as we talked about, non-compliance is not an indication to switch from warfarin to a NOVAC. I'm going to say a few words about managing bleeding in patients on NOVAX. Again, we talked about the fact that there are no reversal agents that are currently available. So the majority of the treatment is going to be supportive while we wait for the drug to wear off. There are a couple of things that I would like you to remember that could be used to partially reverse the effect. One is prothrombin complex concentrates, and the other one is recombinant factor 7A. So this may show up on the exam, but it's definitely an important thing to keep in mind for practice until we have some specific reversal agents that become available. I'm going to talk about some special circumstances that may arise. One is cardioversion and how to manage anticoagulation in this situation. So if a patient has atrial fibrillation that is of known duration, less than 48 hours, you can cardiovert without doing a TEE or with prior anticoagulation. On the other hand, if the duration of AF is unknown or if AF has been around for more than 48 hours, patients should be anticoagulated at least for 3 weeks prior to cardioversion, or they should have a transesophageal echo to rule out a thrombus. Regardless, after cardioversion, everybody should be anticoagulated at least for 4 weeks. And this applies whether you're doing pharmacological cardioversion or electrical cardioversion. Another question that comes up is who to bridge. I think the two dominant indications to bridge would be mechanical mitral valve or any mechanical valve and a prior history of stroke or TIA. Whether to bridge a patient who has a high CHADS VAS score could be debated, and I think this really has to be a nuanced decision depending on thromboembolism risk and bleeding risk in a patient. How about the role of clopidogrel and aspirin? We certainly have trial data on this, and we know that warfarin is superior to aspirin and clopidogrel combination. So the combination should not be used in isolation to prevent just stroke and atrial fibrillation. If a patient is not a warfarin candidate, the combination of aspirin and clopidogrel is better than aspirin in preventing a stroke, but it comes at an expense of increased risk for major bleeds. I'm going to make one last comment on something that commonly appears in practice, but I doubt if this is really going to be on the examination, but I really want to touch upon this. And that's the question of triple therapy following a PCI, whether it's in the situation of elective PCI or following an acute coronary syndrome. And a trial that's really worth mentioning in this regard is the WOST trial. What they did was they took patients who had a PCI, including after an ACS, and randomized them to either double therapy, where patients received only clopidogrel plus warfarin, versus triple therapy, where they received aspirin, clopidogrel, and warfarin. And what they found was that with double therapy compared to triple therapy, there was really no increased risk for thrombotic complications such as in-stent stenosis or thrombosis. But what is significant is that there was a reduction in major bleeding in the double therapy group compared to the triple therapy group. The American Heart Association guidelines are fairly silent on what to do with this situation, but there is a very recent document from the ESC, which I think is worth looking into for practice sake. And I've just summarized a few things here. If a CHADS2 VAS score is less than 2, we don't have to anticoagulate. The patient can be on dual antiplatelet therapy. On the other hand, if the CHADS2 VAS score is greater than 2, we have to minimize the duration of triple therapy. So the recommendation is to do triple therapy for 4 weeks, followed by dual therapy where we drop aspirin from this combination. Now, in recognition of the WOST trial, they also go on to say that if a patient is truly at low risk for stent thrombosis, then you could consider going directly to double therapy instead of giving them a month of triple therapy. So to summarize, things to remember are we have to use the CHADS2 VAS score for assessing stroke risk in these patients. If the CHADS2 VAS score is greater than or equal to 2, patients should be anticoagulated after considering the bleeding risk. The decision to anticoagulate should be based on the risk score and other risk factors that are present, not necessarily based on the rate or rhythm control approach that we take to treat the atrial fibrillation. If there is valvular atrial fibrillation, warfarin is the agent of choice. NOACs should not be used. If a NOAC is chosen, patients should be monitored for renal function and dose adjusted for renal function. Thank you very much. I think we are going to go back to our questions and take a look.
Okay, so while we're on this board pearl slide, can you tell us how you define valvular AF?
So it's also there in one of your slides, but valvular atrial fibrillation would include people who have a history of rheumatic mitral valve disease. Number 2, patients who have had mitral valve repair, or if a patient has had any type of prosthetic valve anywhere in the heart. So those are the 3 situations that the guidelines would consider valvular atrial fibrillation.
And then the other question that came in from the audience was, what counts as vascular disease in the CHADS2 VAS score?
So a history of prior MI, the studies that looked at validating the CHADS VAS score did not consider asymptomatic coronary artery disease. So if a patient has had a prior MI, that goes into that risk. A history of peripheral arterial disease is included, and any aortic plaque and AAA kind of situation would all be included in that risk factor.
And carotid stenosis?
I don't believe carotid stenosis was included in the original studies. It was peripheral arterial disease in the lower extremities, I believe.
Okay. Excellent. So let's go through those questions again. So the first one is a 67-year-old woman with a history of PAF. She underwent PVI. 6 months later, she reports complete freedom of symptoms from her AF. She's on metoprolol and apixaban, and she wants to know if she can stop the apixaban. So the question is, what do you tell her? Should we stop the apixaban and start aspirin 325? Do a prolonged ambulatory ECG and stop the apixaban if there's no AF? Tell her you need to continue the apixaban, or stop and refer her for left atrial appendage closure? Good. 95%. Nice job.
Very nice. Yep. So going back to the question stem, this is a patient who essentially has a CHADS2 VAS score of 3. So age over 65, she's a woman and has a history of hypertension. So even if we think that we have cured her atrial fibrillation, which I don't think is really possible at this point, but even if we think we got rid of it, these patients continue to be at risk for stroke based on their other risk factors, and they should be continued on an anticoagulation based on the CHADS2 VAS score. So the majority got it right, and so that's the pretest. So a significant shift. So very happy to see that.
Yeah, nice job. Question number 2 is a 77-year-old woman with a history of AFib, hypertension, and a mechanical mitral valve replacement referred for management of her AF. She's on amio, metoprolol, and warfarin. CBC is normal, INR is 3.1, creatinine clearance of 45, normal EF, trivial MR, and severe enlargement of the left atrium. She wants to know about dabigatran, and so what should we tell her? We can go ahead and start it at the reduced dose to 75 BID. Tell her that the use of amiodarone will reduce the plasma concentration of dabigatran, that it's actually contraindicated, or that the risk of hemorrhage is similar between dabigatran and warfarin.
Fantastic.
Very good.
So this is a patient with a mechanical mitral valve, so would be considered to have valvular atrial fibrillation. In fact, dabigatran is probably the only NOAC that has had a trial in patients with valvular AF, or rather mechanical mitral valves and other mechanical valves. And what was noted was an increase in thrombotic risk on the valve if patients are on dabigatran compared to warfarin. So absolutely contraindicated in this situation. If the patient didn't have valvular atrial fibrillation, a reduced dose dabigatran would have been reasonable. Amiodarone increases the plasma concentration for dabigatran, like we talked about. So again, the right choice is C. Dabigatran is contraindicated. And in fact, if this is any other NOAC, again, we don't want to be using any other NOAC in this situation.
All right, and the third question. An 82-year-old woman presents with new onset of palpitations and fatigue. She's got coronary disease and hypertension. Her weight is 58. She's got an irregular pulse at 142, normal blood pressure. Her ECG confirms AFib. CBC and thyroid are normal. Creatinine is 1.6 with a low GFR. She has normal ejection fraction and severe LA enlargement. She's on metoprolol BID, and 2 weeks later she reports complete resolution of symptoms and her heart rate is 92. While discussing strategies to prevent stroke, she states that she is not interested in warfarin therapy. Which of the following is the best step for this patient? Aspirin and clopidogrel, apixaban at 5, rivaroxaban, apixaban at 2.5, or aspirin 325.
Great. So again, going back to the question stem, This is a patient who has a very high CHADS VAS score, so 2 points for her age, a point for her gender, and 2 more points for coronary artery disease and hypertension, so that gives us a score of 5. She should be anticoagulated. Warfarin would be a good choice for her, but she's not interested in it. And when looking at apixaban, comes down to dose adjustment. So again, to highlight 3 things to remember with dose adjustment for apixaban: if the age is over 80, weight is less than 60 kilograms, or creatinine is greater than 1.5, if 2 of these 3 exist, then you have to cut the dose in half and give 2.5 BID.
All right. Thank you very much. Great job.
Thank you.